Thank you for joining us today. I'd like to welcome you all to today's webinar, Implementation of SBIRT onto Electronic Health Records from Documentation to Data, featuring John R. McAteer. At this time, I'd like to go over a few housekeeping items for today's webinar. We'd like to encourage you all to participate in today's webinar via three methods. First, if you have any questions for our speaker or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Periodically throughout the presentation, John will stop and ask for questions, at which time I will read aloud any questions that have been submitted. Again, you can submit questions via the comment or questions box. Throughout the webinar, all participants will be on mute. If for any reason you would like to be unmuted, please click the Raise Your Hand request and unmute your personal phone or mic. I, as the organizer, will unmute you to speak directly onto the webinar. You are also able to collapse and expand the GoToWebinar panel via the arrow button should you choose. 1 hour following the webinar, you will receive the evaluation and continuing education request information. This webinar is approved for 1.5 PCB or NADEC credits. You can also request a general certificate of attendance. I'll go over all of this again at the conclusion of the webinar. At this time, I'd like to go through 4 poll questions. We'd like to get a picture of the demographics and SBIRT experience of the audience. These questions will appear on the screen as an interactive poll. Please select the best answer as it applies to you. What is your current professional role? Counselor, therapist, social worker, or case manager, nurse, nurse practitioner, physician or physician's assistant, program or unit administrator, university student or faculty, or other. Okay, I'd like to thank everyone for participating in that poll, and I'm going to share the results with you. If you selected other, please feel free to type into the questions box or the chat panel what your professional role is. We'd love to share that with our speaker as well as all the other attendees. And our next question is, which field do you represent? Mental health, addictions, physical health, education, or EAP? And again, if none of these apply to you, feel free to respond in the questions box or the chat box. Okay, great. I'd like to thank everyone for participating in that poll, and I'm going to share those results as well. Looks like a majority of our attendees represent the addictions field. I'm also seeing coming into the questions box that we have a professional role of researcher or trainer, a project manager, behavioral health field, a data lead for program support specialist, and an FQHC health. For our third question, do you conduct SBIRT interventions? Okay, great. I'd like to thank everyone for participating in that poll. And here are the results. 79% said no, they do not conduct SBIRT interventions. I'd also like to share that from the questions box, we have a comment that this individual trains others to do the intervention. And for our last question, do you see your agency using SBIRT? Okay, great. I want to thank everyone for participating in that poll, and I'm going to share those results as well. I also have a comment here that this person's agency does not conduct the interventions, but the community providers will. Okay, great. Thank you all for completing the polls. I'd like to let everyone know that we are recording this webinar, and you will be able to access the recording following the webinar. Now I'd like to introduce today's speaker, Mr. John McAteer. John McAteer is the SBIRT Healthcare Systems Coordinator in the Bureau of Alcohol and Drug Use Prevention, Care and Treatment of the New York City Department of Health and Mental Hygiene. In this role, Mr. McAteer trains New York City healthcare providers in SBIRT and supports practices to implement SBIRT into their routine workflow, including integration into the electronic health record. He has also collaborated to develop a health department SBIRT curriculum tailored for providers who care for patients with hepatitis and an outline SBIRT learning module. Mr. McAteer received his master's in social work from Columbia University's School of Social Work. Prior to his current position, he was the Director of Chemical Dependency Treatment Services at Long Island Consultation Center. Mr. McAteer continues to work as a therapist in private practice, serving adolescents and their families, and focusing on substance use and mental health. Okay, John, if you're ready to go, I can turn things over to you.
I'm ready.
And that looks great.
All right, excellent. All right, so we're ready to go. You can hear me okay?
Yep, you sound great.
Okay, great. Thank you. So good afternoon, everyone. Big thank you to Irita for this opportunity to really share our New York City SBIRT implementation initiative, as well as our experience with the integration of SBIRT onto various electronic health records. On a personal note, this work has really ignited a passion for me to find the right tension, to find the right balance between the identification of useful data, clinical utility, documentation, workflow, as well as the best utilization of staff within the context of SBIRT. So what I have here is some learning objectives for this presentation. What I'm hoping will come across is the ability to really recognize the key considerations of implementing screening, brief intervention, and referral to treatment into healthcare practices. This really includes various implementation models, validated screening and assessment tools, and the composition of a thoughtful implementation team. We look to identify a range of options for integrating SBIRT onto the electronic health record via templates or alerts. We're looking to describe how the electronic health record integration can facilitate SBIRT delivery. And we're looking to explain how SBIRT data extracted from the EHR can be used for quality improvement activities. And here's an outline in regards to what we're going to be covering during this talk. I'm going to go into some New York City specific alcohol-related epidemiology. I'm going to do a brief overview of what SBIRT is. I'm going to talk a little bit about our New York City SBIRT initiatives, and then I'm going to go into the range of options for the integration of SBIRT onto the EHR. We're going to talk about some of our early experiences with the EHR integration, as well as our current approach, and the benefits and challenges that we found through EHR integration, and we'll conclude with conclusions. So now a little bit about New York City alcohol-related epidemiology. The graph that you see shows alcohol consumption in New York City using data from our 2011 Community Health Survey. Overall, 55% of respondents report any alcohol use in the past 30 days. 19% of adults report drinking excessively, and 18% report binge drinking. Note that there's substantial overlap between these last two categories. And what I mean by that is the 19% who report drinking excessively, of that group, 18% actually engage in binge drinking. The graph here shows that alcohol use also poses a large burden to healthcare systems. About 1 in 10 hospitalizations in New York City are alcohol-related. This graph shows the substantial public health impact that alcohol use has in New York City. In 2011, alcohol was attributed to the deaths of more than 1,700 New Yorkers. This includes the direct effects of alcohol, alcohol-related deaths from injury and violence, and several other alcohol-related causes. Switching gears a little bit to screening, Our survey data also indicated that despite the substantial impact of alcohol on the health of New Yorkers, only about 1 in 4 New York City adults report to a doctor, nurse, or other health professional has asked or even talked to them about their alcohol use within this past year. From this statistic, we could see that screening for alcohol was generally not a routine part of clinical care for adults in New York City. Some potential reasons for this are likely multifactorial, perhaps competing demands on time, lack of familiarity with screening tools, or how best to address the drinking patterns identified through screening. So this really presents an important and exciting opportunity to introduce SBIRT into primary care. Now to talk a little bit about what SBIRT is. So it's an evidence-based approach to address risky alcohol and substance use through universal screening. The goal is to identify patients that are at risk for unhealthy substance use, or in other words, the focus here is really less on patients who have a diagnosable disorder and more on those patients who are at risk for developing one. SBIRT has 3 main components: screening using a validated screening tool such as the audit, the brief intervention, which is essentially a short conversation about the patient's screening score with a plan for follow-up, and referral to treatment when indicated. So SBIRT is also effective. It's been found to reduce alcohol consumption and decrease healthcare utilization, which could lead to fewer hospitalizations and lower healthcare costs. SBIRT is recommended by the U.S. Preventative Services Task Force and Community Preventative Services Task Force, and it's ranked as one of the 5 most effective clinical preventative services. So there's several validated screening tools which could be used to deliver SBIRT. First off, we have the National Institute on Alcohol Abuse and Alcoholism, or NIAAA. Their screen asks, how many times in the past year have you had X or more drinks in a day? So X is defined as 5 for men and 4 for women. A positive response to the single question screen is defined as 1 or more. This is the Alcohol Use Disorders Identification Test, or audit, and audit C. And they ask about, the audit C specifically asks about the frequency of drinking, amount of alcohol consumed, as well as frequency of heavy drinking. The single question drug screen asks how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons. The drug abuse screening test asks, during the past year, have you used drugs other than those prescribed for medical reasons? And it's also including the use of prescription or over-the-counter drugs in excess of the directions and any non-medical use of drugs. And lastly, we have the CRAFT screening tool for adolescents, which screens alcohol and drugs. What we really hope to highlight here through this talk is an algorithm of SBIRT integration, which can be applied to any screening tool, where there is an initial screen, a full screen, or assessment, which leads to an intervention based on risk levels. Because there's many examples of these screens, what I'm going to focus on mainly is the implementation of the audit, and I hope to be descriptive enough so the applications to other screenings are clear. The audit stands for the Alcohol Use Disorders Identification Test and was developed and validated by the World Health Organization. It's brief, it's 10-item screen that indicates a patient's alcohol risk level. The audit provides a framework for intervention by identifying hazardous and harmful alcohol use. The reference point for this screen is the past 12 months. The audit is not a diagnostic tool, but more of a reliable indicator of the presence or absence of unhealthy use. Before we move forward, I just want to clarify some of the language that we use referring to the screening. So for example, the audit C, which is the first 3 questions of the audit, can be considered either the screen or the pre-screen. The assessment or full screen are the additional 7 questions asked when this pre-screen is positive. A strength of the audit is that it identifies that full spectrum of alcohol use, all the way from at-risk to alcohol use disorder, which allows us to really stratify those interventions for a patient, from general education to a brief intervention where we're utilizing clinical tools to assist the patient in identifying really their own reasons to stop, cut down, or make that referral for specialty care. Whoops. Whoops. So here are a few basics about what a brief intervention is and what it's trying to do. First off, it's meant to be short. Brief interventions are reimbursable if they last a minimum of 15 minutes, but keep in mind that even much briefer sessions, even lasting just a few minutes, have been effective in some studies. Brief intervention is guided by the screening result, which indicates whether a patient has unhealthy drug or alcohol use. The purpose of the brief intervention is to have a motivational discussion with the patient about their problem areas and possible approaches with ease and without judgment. Motivation is often fueled by education, so we start by informing the patient and interpreting the screening results. Then we're giving clear feedback about the potential for risks and consequences of their substance use. Feedback and recommendations are given respectfully and, where possible, relate directly to the patient's own health conditions and goals. The focus of the brief intervention is on motivating the patient to take action and increase their commitment to change. In a small percentage of patients, the screening results will indicate high risk use or dependence. Brief interventions are not intended to treat those with more severe conditions, which typically require that referral to specialty care for comprehensive substance use assessment and treatment. It's not a brief intervention per se. However, what we use are the clinician's approaches of engaging the patient in this discussion, acceptance, and follow through of the referral really is following those that same pattern as the brief interventions. Now, before I move on to the our New York City SBIRT initiative, are there any questions?
We do not have any questions at this time, but I just want to remind everyone that you can submit any questions you have to the questions box or the chat box, and then they will be read aloud during the question and answer period.
Great. So now we're going to talk a little bit about our New York City SBIRT implementation initiative into the healthcare practices of New York City. So we started this initiative in 2012. And our goal was really to promote SBIRT into the New York City primary care practices. We used what we like to call a systems approach, which I'm going to go into greater detail about later in the presentation. To date, we've been able to assist the implementation at more than 50 practice sites across New York City. And we've been able to implement onto 4 different EHR platforms, including Epic, eClinicalWorks, GE Centricity, as well as MD Land. And here we have a clinical program guide that we developed in collaboration with the Institute for Family Health and Epic Central. It's available in PDF format on the Epic website, and really we put it together to be a resource guide for practices in the development of the SBIRT tools onto the Epic electronic health record. So who has participated in this implementation initiative? We've had a wide range of sites which really were successful in the implementation of SBIRT. They include federally qualified health centers, community health centers, small practices which we consider to be practices that have 1 to 2 medical providers, school-based health centers, as well as emergency departments. Our model has the following components. So we engage new practices through various outreach activities. We also conduct monthly New York State approved 4-hour trainings on how to perform SBIRT here at the health department. For those that are interested in our initiative, we offer technical assistance that's comprised of 5 basic steps. So we look to identify the implementation team, conduct workflow assessments at various sites of a practice, integrate SBIRT onto the electronic health record, provide instruction in billing and coding for SBIRT services, as well as facilitating the referral process. We also engage in ongoing data-informed practice coaching and technical assistance. The first step we take is to identify an implementation team. And we found that assigning staff members with specific roles for this initiative really helps the practice to take ownership of it. We found that typically the following staff compose a successful team. So we have practice administrators, clinical staff, which include physicians, NPs, PAs, nurses, social workers, medical assistants, informatics staff for data identification and retrieval, as well as billing staff. Getting the multidisciplinary team together really helps us understand the goals of SBIRT integration. We understand that providers are not screening in a vacuum. The reason why a practice is implementing will influence the integration as well as the clinical intersections with other screenings and interventions. What we found through our implementation initiative is that, looking at the workflow and understanding that SBIRT screening is also happening in addition to PHQ-9 screening, smoking cessation, things like that, we have to come up with a really thoughtful way to implement this as to not burden any one staff. So here are some important implementations for consideration. In New York State, in order to bill for SBIRT services, providers need to be trained and certified, or the licensed providers need to be trained and certified. Some of the barriers that we've experienced are time, workflow, lack of knowledge, and stigma. When I mention stigma, I'm talking about there are providers with varying levels of comfort with asking patients about their alcohol or substance use. Patients don't feel stigmatized by discussing this information. We can implement SBIRT in health centers. There's a variety of implementation models as well. What we've learned through our implementation efforts is if you've established a workflow for one practice, you've really established a workflow for that practice exclusively. Each practice site have various workflows depending upon whether it's an initial exam, annual, sick visit, or walk-in. What we've done here is we kind of distilled some different models, which we found through our implementation of SBIRT. So we have what we could call a specialist model, and this is when we're looking to utilize those dedicated non-physician interventionists to conduct all of the SBIRT components. In the vital signs model, we have a nurse, a medical assistant screening the patient, and then the primary care provider really delivers the brief intervention. Lastly, we have a systems approach, and this systems approach really distributes the SBIRT components broadly throughout the regular workflow. So a little bit more about the systems-based approach. So we're looking to have a variety of practice staff incorporated into the process, and the tasks are distributed throughout the normative workflow of a practice. We're looking to avoid bottlenecks and sort of all of the components being piled onto any one provider. What this does is really minimize the time spent by the providers on screening and assessment. Clinically actionable information is then delivered to the primary care provider, and they're able to then wage in on the intervention. A great facilitator of this are the components of SBIRT integrated onto the practice's EHR. This also will help target behavioral health and specialty care referrals. So, during our workflow assessments at the practices, the first thing we consider is sort of physical space. We're looking at waiting areas, triage, and patient exam rooms. Why is this important? So this is important to assure that the area where the screening is being conducted is really private. In one of the practices we've actually implemented in, prior to our work, their baseline for positive screens for substance use were really negligible. They were low, despite their knowledge that they had patients who were using substances. So what we did is we went in and we did an assessment of their physical space, and we found out where they were screening their patients was considered what they called a triage area. It was next to the front desk and feet away from a bustling waiting area. So I don't need to say, but it's not really conducive to screening because the patients, turns out that the patients feel less inclined to be honest when front office staff and other patients can hear their responses. And you have to think, like we said before, these screenings are being delivered amidst other preventative screens. So if I don't have a private area in which to conduct screenings, I'm probably not going to get into my sexual history, smoking status, and the like. We also assess the steps of patient flow. So essentially, in other words, how does a patient move through any kind of visit, either sick, well, annual? You know, in some practices, the patient is triaged into in one room, asked to wait in a waiting area, and then brought to an exam room. In other practices that we've worked with, they are moving more towards having the patient stay in one exam room and each one of the services be brought to the patient. We also consider their present documentation and referral practices. Some of the practices that we work with use paper. Other practices use an electronic health record. And lastly, we identify staff for delivery of SBIRT. You know, who will actually be performing the different components. So before I move on to the integration of SBIRT onto the EHR, are there any questions?
We do have one question. What type of license or certification is required for SBIRT?
So in New York State, and this is, I think, New York State specific, anyone that has a New York State licensure or certification, so a licensed clinical social worker, licensed master social worker, or certified alcohol or substance abuse counselor, requires a 4-hour training in order to conduct and bill for SBIRT. For those who do not have New York State licensure, there are also 12-hour trainings that then certify that provider to conduct SBIRT services.
Okay, great, thank you. We do also have a request for information on the clinical program on EPIC, and John, you and I can pull that information together following the webinar and we can disseminate it to all of the attendees.
That would be great.
And I have one more question that just came in. Is a case management certification eligible for the 4-hour training?
I'm not aware. I mean, keep in mind that this is New York City specific. I'm not sure, but in New York State, I haven't seen a certification necessarily for case management. But if it's certified through New York State, then the 4-hour training would be sufficient.
Great, thank you. And for this person's question, I will send you a link to the OASIS website that has the certification information on it.
Oh, that's awesome. Great.
Okay, that's it. You can go ahead and continue. Thanks, John.
Okay, excellent, excellent. Thank you. Now we're going to talk about our journey in regards to the integration of SBIRT onto the electronic health records. So when integrating SBIRT into the EHR, we assess how it will really fit best into the current workflow at a given practice. So what we're doing is we're really trying to find the right tension between what the providers are currently doing and any new components that we're looking to introduce, right? So we're not looking to introduce a totally new workflow where there's going to be a lot of booster training and practice coaching needed. We're looking to really find a good balance between what the providers are currently doing and how we can best sort of integrate these new initiatives. So just as various as workflows are, so are the different ways that you can integrate SBIRT into your EHR. Up here we have some common elements which include alerts. And what do we need alerts for? So we need alerts for to prompt providers for annual screening, as well as to provide clinical decision support. So we're prompting providers through the steps of SBIRT delivery. We're looking at screening tools, validated screening tools, pre-screen and assessment, which in some EHRs can come in the form of smart forms, which actually calculate the screening scores and risk levels for you. We're looking to integrate documentation of the brief intervention, procedure and visit codes, and in most EHRs, all of these components can be templated to populate the note all together, so nothing is left out. We also have online treatment locators, which enable the providers to give treatment resources to their patients. So our early experiences with the EHR integration was through collaboration with the New York City Department of Health's Primary Care Information Project. This bureau was developed to improve the quality of care in underserved communities through the use of health information technology. They introduced us to primary care and specialty practices who were really interested in gauging their substance use of their patients through SBIRT implementation. So what we did is the DOH staff went to the various practices and entered the screening and brief intervention documentation into structured data fields of their EHR. Now I said structured data, so not everyone knows what structured data is. So when I say structured data, it's simply information that's pre-populated onto the EHR. For example, if I have screening questions, the structured data are the screening questions that I pre-populate, as well as a drop-down of choice responses. The cool thing about structured information in the EHR is that it can be retrieved for data analysis. And that's huge. That's very important. In contrast, we have free text, which a lot of providers utilize in order to kind of catch all of the nuances that are going on with clinical care. The only downside with free text is that it cannot be retrieved for data. So what you see here on your screen are two examples of the audit and the DAS screening tools in the social history section of the progress note, and the platform here is eClinicalWorks. So whether the result of the pre-screen was negative or positive, the full screen populated the note, which was not really the best thing. However, once we completed, we thought, now that it's there, the staff are trained, now they'll start screening, we're good to go. But this wasn't the case. Just because the tools were there doesn't mean they'll be used. And some of the reasons for this were it wasn't a priority in the workflow. Other acute conditions during the visit may complicate things. And here we have a screenshot of the brief intervention that was also put onto eClinicalWorks. So when a patient scored positive on the audit screening, the providers were trained to deliver the brief intervention. Again, the providers were trained, they had the screening and brief intervention tools, were good to go. We gave them practice coaching every 3 months. So we should just wait for the data to roll in. But what was missing was that there was no prompts. There was no prompts for annual screening, as well as no prompts for providers to complete the screening and brief intervention. So we thought, aha, we need alerts. Alerts will solve our problems. So we set alerts. So the alerts were set to conduct annual audit as well as DAS screening for patients who have not received them in the past 12 months. We also created alerts to provide clinical decision support to guide the providers from the screening to the brief intervention, because not all the time, depending upon the EHR, it wasn't always intuitive. So what this included was the various zone risk levels depending upon the patient's screening score. So we have the validated screening tools as structured data in the EHR, and alerts for annual screening and clinical decision support with ongoing practice coaching from us. We felt this was really sufficient to assist our providers in universal screening, but we learned very quickly that providers are really being alerted to do a lot more than just screening and intervening for alcohol and substance use. So you might have heard of this, of alert fatigue, or even experienced it for yourself. We have providers that talk about this all the time. Some of the symptoms of this include frustration from providers, incomplete documentation, which invariably leads to less data. We also learned through our experience that there were hard alerts, which do not let the provider close the note until the documentation is completed. There's also soft alerts, which a provider can ignore. So just because there's an alert to do something does not ensure that it will get done. So what did we learn? What did we learn from this? Some of the lessons we learned from these early experiences were the less clicks within the EHR, the better. And providers actually count clicks. I've worked with providers who say if this is any more than 6 clicks, it greatly decreases the likelihood that I'm going to do it. So what we also learned was that the interpretation of the screening score was really needed, whether it was positive or negative. The assessment tools or the full screens really needed to populate only off of positive screens, because if they're populating off of negative screens as well, we're causing clutter and confusion within that progress note. If we're training, and we were also training providers to really recognize the patient's screening score as a zone or within a zone to really stratify that risk level. So we really needed to designate this. Previously, the assessment or the full screen result was being displayed numerically, and we needed to really emphasize that zone designation. We also learned that the brief intervention could be and needed to be tailored to that zone. So this way, if a patient is drinking at low risk levels, they might not need a full intervention regarding their needs to stop or cut down or anything like that. So it was really, really important to be able to tailor that according to zone. And also, alerts should be reinforced through training with clinical staff. So now that we learned what and how we can improve, this is how we've put what we've learned into practice. So this is SBIRT 2.0, folks. Here we have examples of the Audit C and the CRAFT screening tool for adolescents. As you can see, the provider is prompted to interpret the screening, and only positive screens trigger the rest of the screening questions to populate the note. We have practices who have integrated these pre-screening questions onto their registration paperwork or even through tablet kiosks in their waiting room. The screens are scored by front office staff, entered into the progress note, and then the provider is notified. These screenings can also be completed at triage by a medical assistant, nursing staff, health educator, case manager, or behavioral health staff. As stated before, with the assessments or full screens on an EHR, we're really able to move through the screening and have the patient's risk or zone score identified when the patient scores positive on the screen. This is really the springboard for the intervention or referral to specialty care. There's some practices which chose to have one staff person complete the screen and another to conduct the full screen or assessment in order to, in an effort to distribute the components throughout the workflow. However, some other practices have stated that they prefer to have the same staff complete the full screen if needed, and the reason why is to really help build the rapport with the patient and sort of emphasize the fact that it's okay to talk about this information here and that all of this information is private and confidential and really used to better inform a patient's health care. So we've completed our screening. Now we can move on to the brief intervention. And here we have two examples of brief intervention. The screenshot on the left, or my left, is from GE Centricity, and the other is from eClinicalWorks. Of note, we were able to carry the zone designation from the screening into this brief intervention. So, for example, if the patient's in Zone 1, the provider is prompted to deliver education, so whether it's the federal guidelines for low-risk drinking or reinforcement for positive drinking behaviors, that is all the patient might need. In some of the practices we work with, it's really the medical provider who's providing this education or reinforcement to the patient. In others, a nurse, a health educator, a social worker, behavioral health worker is providing this to the patient. So now keep in mind we're setting up this algorithm for the audit. So for zones 2 through 4, which are really spanning that that moderate to high risk use, providers are prompted to conduct this brief intervention. And what you see here is really a guidance document we use to inform our build of the brief intervention. This first column that you see are the clinical tools that the providers could use. The second column are the questions asked of the patient, and the third column are the values used to populate a drop-down menu of response options. So for example, the patient reports the pros of continued use, right? So what we're doing here is pros and cons, otherwise known as decisional balance, and this is to help amplify ambivalence in our patients. And by asking what the good things of continued use are, or why they like to use, what do they get out of it, it really helps with rapport. And it really expresses an interest from the medical provider as to what the patient is, or why the patient is using. So it's whether relaxation, a chance to meet with peers. So all of this can be customized based upon, I guess, popular responses that providers see. So then the patient is given education or information regarding alcohol use and health. And then the patient measures their importance and their confidence in being able to make any changes towards their alcohol use. So this step really fuels the information that we need to develop an action plan. In a lot of the practices we work with, a nurse, health educator, social worker administers this to the patient in collaboration with their medical provider. And at the end of the day, really what we want this to culminate in is that action plan. So here's an example of the action plan for the patient. And it's really a prime opportunity for care coordination. And this is very popular. I mean, it's very popular, I'm sure, nationwide, but especially in New York State, where there's a lot more emphasis on patients being able to complete referrals. Not only that, but being able to receive feedback from those treatment referrals as to whether or not the patient was successful in making that referral. So having and also having this follow-up plan and structured data also allows us to really retrieve data on patients who were screened or had a brief intervention, what patients require follow-up, what patients have been referred for internal resources, or any patients that were referred for external referrals for specialty care. And lastly, we document how much aggregate time was spent delivering the screen and the brief intervention. So this is something that we've used for eClinicalWorks, but we've also incorporated zone-specific order sets for providers. So if a patient is scoring in a certain zone, what this order set can hold is either educational information for both providers and patients, procedure codes, which also can be templated into the background of the progress note, when the next follow-up appointment will be, as well as treatment locators. So what we actually do, it's not here on the screen because I couldn't find a good screenshot of it, but we actually embed the SAMHSA treatment locator into this order set. And it's really a great resource for that RT of SBIRT, the referral to treatment. So this is important because many providers are not even aware of the treatment resources that are around them. And from my own experience, if I was screening patients for at-risk substance use, I would like to know my referral options and have good relationships with them. And if I don't have these linkages, I would be hesitant to screen in the first place. So those linkages are really important. Quick story, we were implementing SBIRT into a women's health program over here in Queens, and they really were bereft of treatment resources. They had patients that they were identifying needing that referral for specialty care, but really had no linkages or awareness of the linkages of the treatment providers around them. So what I did is we embedded the SAMHSA treatment locator into their electronic health record, and just for fun, as a demo, we put in their address. And it turns out that they had an outpatient substance abuse treatment program in the basement of the building that they were occupying. So it's very important, and it's an important lesson in order to make sure that these resources are available to providers to best refer patients. So assessment and procedure codes, which are integral, can either be linked to specific assessments in the EHR or really added to a template. What this does is really improve the use of SBIRT-specific billing codes, and we use that for billing as well as for tracking purposes as well. So EHR data can be used for quality improvement activities. Structured data can be extracted for reports. So just from the screenshots that I've shown you so far, we could pull the total number of screens, total number of full screens or assessments, total of brief interventions, and the total number of referrals. We can, and this is given to the as feedback to the implementation team during our regular practice coaching sessions. And it really provides insight into the workflow as well as any kind of utilization issues of documentation. And just two quick stories. In one of the practices we work with, through their screening data, we realized that there were many screens being conducted through the use of the Audit C. So they were using the Audit C a lot, almost universally with all of their patients. However, their full screen rates, when the patients were positive, they were incongruent. They didn't match up. So it really gave us the opportunity through practice coaching to identify sort of what the issues were. It turns out that this issue was that the majority of the patients were Spanish speaking, yet the only staff person in the practice who spoke Spanish administered the Audit C. So this really concretized the need for bilingual staff in order to deliver those full screen and brief intervention components. In another practice, we had the same issue, where Audit C screens were being completed almost universally. However, those full screens and assessment were not. The issue was that the full screening questions were located in a different section of the progress note. So essentially, providers forgot this and it wasn't completed. So by looking at the data with the administrative staff, we were able to template the documentation so the screening tools were all in one place. So here's just a few examples of how data can be used to improve screening rates. Other reasons to collect data on SBIRT are to support your practice through the changing landscape of healthcare. So according to the ACA, substance use services are considered an essential health benefit. The 2010 Parity and Equity Act started this work, but it really only applied to a narrowly defined group of the insured. Now it applies to virtually everyone and gives access to about 62 million Americans. And this is really significant to SBIRT utilization in regards to substance use screening and linkages to care. The ACA also promotes the use of health homes, which are networks of providers that really promote intensive care coordination. This new capacity for screening, assessment, and referral is really garnering a lot of interest in the integration of SBIRT into health homes. In New York State specifically, Medicaid redesign is really an accelerator for the ACA. Its provisions are meant to promote care integration intensely because behavioral health services are now being carved in to an integrated managed care benefit. There are also performance-based incentives which also accelerate Medicaid redesign, patient-centered medical home or PMA bonus payments for Medicaid reimbursement, for screening, counseling, and care coordination. And lastly, we have the Delivery System Reform Incentive Payment, or DSRIP, that also supports SBIRT integration into New York State. So now is the right time to integrate SBIRT. Here are some benefits that we found in regards to integration of SBIRT onto the electronic health record. So it really facilitates universal screening for substance use. Why do we sort of emphasize universal screening? It's that providers have those complications which come from substance use on their clinical radar. Screening also provides that sort of professional helping atmosphere. So when patients ask, why are you asking me these questions? We can say, because we ask everybody these questions. It really gives the opportunity for clinical decision support through creative mapping, alerts. SBIRT on the EHR really takes the guesswork out of SBIRT delivery in the healthcare setting. We get to utilize all levels of staff using that systems approach that I talked about before, where all the components of SBIRT are spread throughout the patient visit. We're actually accessing staff to deliver the SBIRT components in really thoughtful ways. We promote the use of validated screening tools. Although we encourage providers to incorporate the screening tools really into a conversation, having the validated screening tools is really important. Actually, when we first started this initiative, we conducted a survey with a lot of the primary care providers in New York City in regards to their current screening habits. How do they ask patients about their alcohol and substance use? And there was a wide range. There was a wide range of responses. Everything from we use validated screening tools to you don't drink, right? Or how often do you drink? Occasionally? Once in a blue moon? So things like that really close the door on screening, and they're not really validated screening tools. And that's another reason why sort of the technical assistance that we offer in the practices is important, is because we can support the fidelity of using these validated screening tools. It also, one of the benefits of SBIRT in EHR integration really assists in care coordination. So a great number of practices that we're working with are utilizing new staff to support behavioral health integration initiatives. So these staff can be utilized for follow-up and assistance in referral completion for patients. We're also utilizing SBIRT data for quality improvement and health reform initiatives. So here we have some challenges regarding SBIRT integration onto the EHR. So there's always this, right? We hear this all the time. There's competing priorities. During a visit, providers have so many preventative screenings which they may have to address. They also have, in addition, any chronic condition the patient may have, as well as the acute conditions that the patient has themselves. It also, when we mention time, it also takes time for providers to build these tools and interventions onto their EHR. Here at the New York City Department of Health, we're really lucky to have staff who could build these tools in consultation with the provider. So that burden is taken off the providers. There's limited staffing and resources. So without additional staff, it can be difficult for practices to really implement SBIRT the way they would like. Although there's a lot of grants and funding opportunities out there for behavioral health integration into primary care, integration with existing staff is really essential in order for sustainability of SBIRT after the grant. So in regards to reimbursement for SBIRT services, here in New York State, reimbursement for SBIRT has been a bit of a quagmire, especially in regards to federally qualified health centers. So the federally qualified health centers who have opted out of ambulatory patient groups, or APGs, which are really the majority of the FQHCs, are paid by a capitated Medicaid rate. Whether they conduct one service during a visit or several, they receive this one rate. So what we hope that two things can really happen in regards to reimbursement for the FQHCs. So we encourage that the FQHCs have the SBIRT CPT codes put onto the fee schedule for their payers, as well as have all staff involved with SBIRT delivery be credentialed to that through those payers. So this way there's a seamless line from payer to staff in regards to delivering SBIRT. And now, also with more managed care Medicaid, we're hoping that FQHCs will be able to bill above their Medicaid rate from the managed care company. And lastly, another challenge is providers may be more familiar with screen and refer approaches rather than this brief intervention model. So some of the providers we have worked with are really used to screening and referring to either behavioral health, social work staff, or referring to outside resources. And really what we've hoped to develop is through these stratified interventions with SBIRT, especially the stratified interventions with SBIRT on the EHR, we're looking to really arm the providers with the tools they need to conduct the risk-appropriate interventions with their patients. So, in conclusion, it's really, really important to have that multidisciplinary implementation team. Our workflow, or the workflow that we develop, really needs to be flexible and tailored to that practice site. There's a range of options that exist for integrating SBIRT into the EHR. EHR integration can greatly facilitate SBIRT delivery. Regular training and support from leadership is also very, very important. SBIRT data can be extracted from the EHR and can be used for quality improvement activities. So a quick thank you for, first off, to IRETA for the opportunity to present this initiative that we're very enthusiastic, we're very excited about, and also some contributors for this to the New York City Department of Health and Mental Hygiene is our Assistant Commissioner, Dr. Hillary Cunnins, Dr. Jessica Catan, who is our Director, as well as collaborations with the Primary Care Information Project, otherwise known as NYC REACH. Thank you very much.
Okay, thanks so much, John. That was a great presentation. We do have a couple of questions in here. The first one is in regards to the manual that you made. So is the details, such as the screenshots for the BHI and the brief intervention, in the manual? And would you be able to provide a link to that manual? And if it's not included, where might that information be accessible?
So the only manual that we were able to create was through Epic. So not all of the screenshots were from that Epic manual. It was really, as I had stated previously, it was an amalgamation of eClinicalWorks. I would say it's probably eClinicalWorks heavy, and those are screenshots that we've actually taken from the providers that we've worked with. But in regards to best practice alerts, which are the alerts for the Epic EMR, the development of smart sets and smart phrases for Epic development, all of that, inclusive of screenshots, are part of the manual.
Okay, great, thank you. For our next question, how do you get physicians to buy into the SBIRT idea?
That's a great question. That's a great question. How do we get physicians to buy into the SBIRT idea? And I think it really boils down to leadership. If we have, I can talk about some practices almost specifically, is that the implementation and uptake regarding medical staff and buy-in is greatly facilitated by sort of executive implementation, buy-in, and training and management, as opposed to practices that do not have that kind of leadership. And that's happened because we've engaged with providers at varying levels. So if we, for example, engage a community health care center through the social work staff, that does not necessarily, and the social work staff might buy in completely. However, how do we permeate? It's very difficult to permeate buy-in on the medical level as well as administrative level. But if we start with buy-in from the administrative level, the medical director, then there's great likelihood that we would be able to get buy-in from the physicians. Also, I find that involving the physicians,
Thanks, sir. Over to it.
We find that having providers really, sorry, we just got interrupted, collaborate on the build of the EHR, of the SBIRT components in the EHR, greatly facilitate their buy-in. So it's really their product, and it also increases their utilization of the tools as well.
Okay, great, thanks. For our next question, what is the price range for your consulting or implementation of SBIRT services?
Right now they are free of charge. Yeah, right now they're free of charge. So a lot of the work that we do with the New York City-based healthcare practices is done at no cost.
Okay, and our next question, do most providers have staff that can modify the EHR to incorporate SBIRT screens? And if not, then what would you suggest?
Okay, so I would say there's about a 50-50 ratio of providers that we've worked with that have their own internal IT staff, and some that have their own internal IT staff, however, do not have the time to be able to do this. The IT staff are usually very small and very busy in a practice. So in regards to that, I think it's left to it's left to collaboration with the IT team if that exists. If not, it's really left to the providers to build these tools themselves.
Okay, before I read this next question, I just want to remind everyone that you can submit any questions that you have to the questions box or the chat box. And if you'd like to speak live on the webinar and ask a direct question to John, feel free to use the raise your hand option in the GoToWebinar taskbar and unmute your personal mic, and I will unmute you so that you can talk live on the webinar. Okay, our next question is SBIRT only New York State based?
No, not at all. It's national. There are a lot of, I'm sorry, was that the end of the question? I just jumped in.
Yes, it was.
Oh, okay, great. No, this is national, and there are some real leaders in regards to SBIRT work throughout the country, specifically Colorado, Wisconsin, Oregon, New Mexico. A lot of the recipients of the initial SAMHSA SBIRT grant a number of years ago really have come up with some great work, and I'm sorry if I'm leaving some of those out, but yeah, this is a national initiative.
Okay, I have a comment here if you'd like to respond to it. This person says, I have been doing SBIRT for 6 months, and we've done over 600 screenings, and the buy-in for providers is the quality of care of patients.
I agree. I agree. My director's raising her hand in salutation. Absolutely. Absolutely. And that's really what we're looking to do, because I find that a lot of the providers want to be asking these questions, but they have limited time. They have 15 or so people waiting in the waiting room. So by asking a close-ended screening questions like you're not drinking right will definitely facilitate, I did my job, I screened, and now I can move on. But using the validated screening tools, we're able to really open up that dialogue.
Okay, I have another comment here. This person says, I just can't see eligible providers such as PAs, PCPs, or DBHs earning the same as a CNA or medical assistant. Do you have any response to those billing questions?
Well, it's really, so I'm sorry, can you repeat the question one more time?
This is in regards to the billing codes, and the concern is with eligible providers such as PAs, PCPs, or DBHs earning the same as CNAs or medical assistants.
Right, being reimbursed at a higher rate, I assume?
Yes.
Okay, got it. Well, it really, fortunately, unfortunately, it boils down to the contract that a practice has with their payer. So I can say that for screening and brief intervention for 15 to 30 minutes, a provider will get paid $70. So in that regard, they might have a contract with their provider, with their payer rather, for $50 for this screening. So that's really what it boils down to. And in a lot of the practices that we work with, let's say, for example, the medical assistant or case manager or health educator is screening, this all potentially could be happening at the same time as the provider meeting with the patient as well. So it's all going to go on to the provider anyway. And that's actually something that I encourage for a couple of reasons. One is because that's really holistic care. It's really collaborative care, and it's also an opportunity for the provider or the medical provider to wage in on the screening results and the intervention, and it's all billed under the provider's visit. So you can charge at that MD level or whatever level could potentially pay the most.
Okay, do we have any other questions? You can feel free to submit them to the questions box at this time, or again, you can use the raise your hand feature. Here's another question. Could you elaborate on how SBIRT can be used to reduce fewer hospitalizations and reduce healthcare costs?
Well, our hope is that through universal screening and identification and treatment at the primary care level, we will be able to substantially decrease the amount of alcohol-related illnesses and injuries that result from these unaddressed, from it not being addressed at all. So we're hoping to really, so there's evidence for this, and MMWR publication online is also yeah, really kind of brings everything together. So I definitely offer that as a resource as well.
Okay, well, if we have no other questions at this time, I just want to go over our continuing education and evaluation information. Thank you, John. That was a great presentation. If anyone else has any additional questions that they didn't get to ask during the webinar, feel free to email us at info@ireta.org, and we'll certainly get those questions to John. At this time, I'd like to go over our evaluation and CEU instructions. You're going to receive a few emails from us following this webinar. In these emails will be a link to a recording of the webinar as well as a PDF version of today's slides. Also included is a link to the evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continuing to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or a NAEDAC or PCB certificate. Should you choose to skip the evaluation and proceed directly to the CEU request page, just leave all of the answers blank in the evaluation. I'd also like to let everyone know of our next upcoming EHR webinar. Will be on January 6th, and it's featuring Jim Winkle. You can register for this at our upcoming webinars page at ireta.org, and there will also be a link to this registration page in the emails you'll be receiving. I'd like to go over just very quickly some of the New York State specific requirements for SBIRT training that John had mentioned previously. And I just want to highlight that this is only specific to New York State. We will send out a link to the OASIS website that has all of these requirements on it as well. And finally, if you are a New York City provider and you're interested in SBIRT implementation, you can feel free to contact John McAteer at his email address or his phone number listed below. Okay, again, I want to thank everyone for joining us today, and if you have any additional questions, feel free to email us at info@ireta.org. Thank you, John, for a great presentation.
Thank you very much.